So I'm here to talk with you guys a little bit about a subject that's very near and dear to my heart, which is kind of psychosocial needs and diabetes. So go ahead and go to the next slide. Our learning objectives today are identifying some of these psychosocial factors that impact diabetes, helping you understand issues with treatment adherence and how to address it, and then learning a little bit about the benefits of adding behavioral health to the healthcare team. Next slide. Wanted to start off with a case example, but before I want to do that, I just also like to give a little bit of background. So I also have a daughter who has type 1 diabetes, so I feel like I live some of these things in my life as well, and I will give some of those examples as we progress through today's talk. But for our case example, this is an example of a patient that would commonly come through the doors here at Humphreys Diabetes Center. We're going to use him again at the end to talk through some behavioral strategies. But I'd like you to think about Mr. V, who presents for treatment with an A1C of 11 and needs some support with lifestyle change. Um, so try to imagine as we talk through these elements, what kind of psychosocial factors might be coming up for him and how it may be affecting his diabetes management. So he's 60 years old, lives with his wife, who's a great cook. He has a very high stress job. He's thinking about retirement, but he's really worried about finances and whether or not they're going to have enough. He's got multiple health issues, which most of our patients with diabetes experience. So hypertension, he's had some mild neuropathy and some insomnia because of the worry. He struggles with obesity. He used to enjoy a lot of outdoor recreation, but now the neuropathy gets in the way. Used to fly fish, feels like he can't tie the flies as well anymore, worries a little bit more about he's unsteady on his feet. So he and his wife have kind of gotten into this pattern of going out to dinner as their primary source of entertainment. He's had diabetes now for 15 years, used to be really active, but that has really slowed over time as pain, time, stress are all factors that get in the way. We've noticed a pattern with his A1C. It just keeps gradually creeping up, and now we're at that 11 level, and he takes metformin, but really wants to avoid insulin. Okay, next slide. So hopefully, as I was discussing this case, you could start thinking about some of these areas of impact that might be affecting Mr. B. And I use this slide in pretty much every presentation that I give because I like the visual of it. And if nothing else, if this is your takeaway, it gives you a great way to talk with patients about the impact of diabetes. It also can really help you formulate ideas for areas of intervention. So when we talk about chronic disease, we oftentimes focus right in on the physical, right? We're medical professionals. That's what we're interested in is kind of the disease process and what we're going to do to treat it. However, there are all these other psychological, social, cognitive factors that go hand in hand with chronic disease management. And so starting to understand some of these things and query some of these things in your interviews can really help you better support patients and problem solve when you're bumping into issues. So just a couple of things here. I think financial impact is a great one to start with. This is something sometimes patients talk a lot about and sometimes they don't. We actually had an example when we were supporting behavioral health in our Fruitland clinic of somebody who kept ending up in the ED over and over again, and nobody could figure it out. And when behavioral health got in there, it turns out he was really limiting the amount of insulin he over time. So he was breaking it up into several doses, much smaller than what he was supposed to be taking because of financial reasons, and had been too embarrassed to discuss that with his primary care provider. So just thinking about that and asking families about that, making sure it's on your radar and helping connect them to some of the pharma resources that we have when they need it. There can be a career impact to this. I work with patients with both type 1 and type 2 diabetes. An example here would be I had a young man in his mid 20s who was a construction worker whose blood sugar on that CGM was just routinely in the upper 300s. And as we started talking about that, he did roofing sometimes and was incredibly worried about falling off the roof. So figured it was better to be high than low and just left that blood sugar running in that range. We see kind of this mental impact where a lot of our patients will experience issues with cognition related to their diabetes. Also, some of our pediatric patients really need 504 accommodations around not taking tests when blood sugars are too high or too low, having some additional supports in place because we do see that impact, especially with attention, memory, concentration, problem solving when glucose levels are outside of range. There's an emotional impact. So many of our patients struggle with more anxiety and depression, just frustration, feelings of helplessness and hopelessness. Socially, they feel like diabetes gets in the way. Maybe my favorite thing used to be to go have beer and pizza with the guys on the weekend, and yet I'm supposed to be avoiding both of those things. But then I feel left out of my situation with my peers. And then it impacts the family. There's definitely this bi-directional relationship between the disease impacting the family and the family impacting the disease. So sometimes pulling in additional family members or learning about those dynamics can help you understand more about what some of these barriers might be. Next slide. So why are social psychosocial issues coming up? Some of them are the things I just talked about, but also just remembering diabetes is an incredibly demanding condition to manage. We've got these multi-factor areas of treatment, and that's really one of the areas that evidence shows contributes directly to poorer adherence. The regimen also varies. So, especially for our patients who are on insulin and counting carbohydrates, they're taking different amounts of medication. They may need to be adjusting things when they're ill or when they're stressed or when they're exercising or when they're not exercising. So, all of these moving parts create a much more complicated management and create more areas for error and also more areas for guilt, right? People want to take care of their health. And so, when these problems are coming up and they're struggling with it, that tends to breed more guilt. We know there are many factors that impact blood glucose, not just what we eat. And I think this is an important thing to explore with patients to find out what's driving it. Mentioned the cognitive demands. We also see this phenomenon of learned helplessness that occurs in diabetes. I'd say I see this a great deal with teens who are struggling with changing hormones, stress, schedule that doesn't necessarily meet it, and they feel like no matter what they do, their numbers are high, so why try? So helping families and helping patients understand and overcome some of these challenges, getting some success. And I actually think this is one area that our GLP-1s have really helped with is people are finally starting to see some progress with weight management and better control of their diabetes. Let's not forget the fact that we live in an obesogenic culture. So when you're trying to make healthy choices, and I can give you an example, I was just traveling to the obesity medicine conference, and I found myself in the airport when it was time for dinner, and to find a healthy choice was few and far between, especially in certain airports. So people are working and living and trying to function in a culture that really doesn't support health choices that they're trying to make. So it's easy to slide because of those environmental factors. We mentioned financial demands and social influences. And then the other piece is just human behavior. By our very nature, right? We're much more drawn to kind of immediate gratification. And so when you're thinking about these long-term consequences versus, gosh, it sure feels good to lay on the couch and watch Netflix, or that chocolate is calling me, I've had a stressful day, we're asking people to kind of overcome those natural instincts, and that can be really challenging. Next slide. A couple of other just points around psychosocial impact. This grief and loss is something I feel like we don't give enough attention to. So this is the case for all chronic disease. There's this, loss of good health. And then as we go across the lifespan, we notice it in different areas. So, for children with type 1 diabetes, for example, maybe it's feeling like parents aren't feeling safe to have them participate in activities like birthday parties or sleepovers. In teens, parents really try to hang on to that control, and that goes exactly against the developmental norms. That can create challenges. People are entering like early adulthood, and sometimes issues like with dating, for example, who's going to want to be with me if I have this chronic condition, and so on. So just thinking about that grief and loss and whether or not that's part of the picture and part of the challenge that the patient is facing. A lot of people will talk about there are just like too many balls in the air when it comes to managing their daily life and managing what they're eating and the medication they're taking and their medical appointments and work and financial obligations of diabetes treatment. So trying to simplify those as we can really be helpful. We definitely, as I noted, see more anxiety and depression. So we really want to be screening for these in our patients with diabetes. 30 to 50% of people are experiencing some kind of emotional distress. And so it's much higher than the general population. We also see a lot of the psychotropic medications contribute to insulin resistance, especially some of our atypical antipsychotics. So watching out for that and working with the pharmacy teams and psychiatry around trying to pick the most diabetes-friendly medications and the most weight-neutral medications. And then we also, when we look at just the data on per patient costs per month in healthcare, when people have diabetes plus some behavioral health issue like anxiety or depression, costs increase dramatically, like 124%. So lots of reasons to be focusing on these issues. Next slide. I do want to just mention briefly, this could be a whole talk in and of itself, but we do see disordered eating as a common phenomenon in patients with both type 1 and type 2 diabetes. So higher levels of disordered eating than the general population. Most of these people fall into a subclinical level. So it's not that they meet criteria for bulimia or anorexia. Some may meet criteria for binge eating disorder, but definitely see the presence of some of these disordered behaviors that can then lead to an eating disorder, but definitely impact management even at the subclinical level. Most of the research that we have on diabetes and disordered eating is in the teen and young adult population. So there's definitely lots of opportunity to learn more here. But estimates are that it's upwards of 40% have some kind of eating disorder. As I mentioned, in type 2, it's pretty poorly researched, but definitely seeing higher rates of binge eating, night eating, and overeating. And that's actually one of the areas that we've started to support here at the Diabetes Center is we have a binge eating group, an emotional eating group to help patients with some of that emotional regulation. There's also this phenomenon called diabulimia. That's not in the DSM. It's kind of in the just other areas of the literature where people are engaging in binge eating behaviors, which raise blood sugar up. And as most of us know, when blood sugar is really high, we can actually see a pretty rapid weight decline. So then they omit the insulin, binge, bring the blood sugar up, don't take the insulin, leave it up there, and people can drop weight pretty quickly. The problem is this has a number of very high health risk factors. But you can start to see the psychological dynamic of that, especially with some of our teens and young adults who it's like, wow, I can eat whatever I want. And as long as I don't take my insulin, I'm actually going to drop weight. Prevalence is estimated to be somewhere around the 14 to 36% rate in patients with diabetes who report some kind of insulin misuse as a method of weight control. So knowing this, I definitely encourage you to have screening tools available. It doesn't have to be with every patient, but as you're doing your clinical interviewing, and if you're getting the sense that like, wow, I have some concerns here, the BED7 is a 7-item questionnaire that's a great quick screen for binge eating. There's the EDO and then the SCOFF, and any of those could be used and are well-validated tools. Next slide. So let's talk about adherence for a minute. I feel like I get a lot of referrals around adherence. I definitely hear the frustration from our great educators and physicians. Like we've talked about this. They know what to do. I don't know why they're not doing it. Or why they tell me things are going fine and then I download the CGM and it's like things are not fine. Part of this is just, again, this human nature that poor adherence, when we look at the data, really is the norm. Rates are usually below 50%. So having this expectation as healthcare providers that they should be at like this 80 or 90% really is a setup and unrealistic. So instead, I think just normalizing this with patients, that this is a challenging disease to manage, and let's just address and problem solve when we're struggling with adherence. I would also say we know that self-report of adherence is generally pretty skewed. Again, that's not because they're lying. This is just human nature. We tend to over-report our successes and we tend to under-report issues as just kind of a social dynamic. So being aware of that, jumping into your data can really help with that. Top reasons I see for poor adherence. Number one really is forgetting. Many of our patients, especially who are on insulin, will talk about it feeling like Groundhog Day. Like, I swear, I think I just checked my blood sugar. I just took that insulin, and yet they may have missed doses. We see the fact that we have to have varied dosing based on symptoms, based on situations, based on stress, based on carbs is definitely something that's going to create more issues with adherence, as I mentioned, and then schedule disruptions. So times when we're on vacation, we have a meeting at work we didn't expect, those are going to be challenging times for adherence. So as a preventive strategy, talking with patients about those things in advance, making a plan for that can really be helpful using some good motivational interviewing. Next slide. So, some additional ways to help improve adherence besides that prevention piece is actually using what we call the contextual interview. This comes out of integrated behavioral health. And the idea is that we think about the problem within a context of that person's life. And we can ask about the three T's with the problem: time, trigger, trajectory, to learn a little bit more about it. And then figuring out the context: what's going on with work, what's happening in your close relationship with friends and family, what are you doing for fun and recreation? And then let's look at those health factors of sleep, eating habits, movement, substance use can often lead to a lot of clues about what's happening with the adherence, as well as give you some ideas for intervention. So trying to identify really what's the barrier with some kind of functional assessment, and then being able to problem solve those exterior barriers. And then things like poor motivation, using motivational interviewing, helping people connect with their values, building awareness and understanding can really help address some of those internal barriers with motivation and learned helplessness. Next slide. Another tool that you can use in your practice, this seems incredibly simple. I actually learned this from a psychologist who works with the CF population, Alexandra Quintner, but I really like it. So it's just, you take out a piece of paper, you can use a Post-it, you can write it on the exam room table paper, whatever you have that works. But let's just identify, and actually if we start in that upper right-hand corner, what are you doing currently that's not working, right? Let's acknowledge what you're doing and kind of what you've already learned. And are there any things that do work? What are the exceptions to that? What are the times that you are on track and we see things working well? And then both people generate ideas: patient, family, physician, educator, whoever's in the room, and then coming up with a concrete plan of what we want to do about that. Simple way to just structure the conversation and get things moving in the right direction. Next slide. So this is my plug for why I want you to include behavioral health. Behavior change is really required for all the other elements of treatment in diabetes when it comes to dietary change, exercise, following your medical regimen, and healthy lifestyle. And yet we often don't support it. So people typically know what they're supposed to do. They're just like, I just can't do it. I don't know how to do it. I don't know what's wrong. I know it, I get it, but it's not happening. And so that leads to feelings of frustration. People feel like a failure. We might see some of that learned helplessness. And so they're like, forget it. I'm just going to give up. I'm going for the chocolate. I'm going to eat what I want. I'm going to lay on the couch and watch my Netflix, or I'm going to skip my meds. So adding a behavioral health team member early on, who can be just seen as a regular part of good care, who's there to support patients with behavior change, who can also address things like stress management, coping, anxiety, depression if they crop up. Patients can come in and leave care as needed, but they're there in the background and as a safety net to help address those issues. Next slide. Before I hop onto this, I do want to mention Humphreys Diabetes Center is available for this. We now have 5 members on our behavioral health team. We can provide telehealth across the state, and we have 1 clinician who is licensed in Oregon. So you can refer to Humphreys just for behavioral health support for your patients with diabetes, and I encourage you to use this as a resource. So a couple of other just kind of tricks to have up your sleeve when you're talking with patients about behavior change. One is just the very nature of behavior change. Diabetes can be a very demoralizing condition because people, kind of get started and they're working hard, and then life happens and they get off track, and then they have a host of reasons that they feel like a bad person or feel guilty that that's happening. And when you can normalize that experience, that what people expect when it comes to health change is that we start at the bottom and we make this lovely progress forward, really isn't reality. What we see instead is people start to make change, and then something happens in their life and they get off track, right? So maybe it's January 1st and we have a great idea of what we're going to do for our New Year's resolution, and we're going in a great direction, and then the Super Bowl happens, boop, and we're off track. And then we kind of get back on track, and then Valentine's Day happens. But being able to map those things out, normalize that for patients, and then identify what was happening in that upward trend. What were you doing there that seemed to be working for you? And then what were the triggers that really launched that downward trend? When people can start to understand those patterns, when they can look at this as data without judgment, they become much better problem solvers. Next slide. Okay, functional assessment. You guys are getting the whirlwind cliff notes here, but this is another tool that you can use in your practice as a way to help problem solve and figure out what's going on. So I call this the behavior pyramid when I work with patients, and I have this graphic and a couple of others, but the idea is we've got this environmental piece, that's the base of the pyramid where things are grounded, and then we have these other three sides. So what do we think? What are our beliefs? What are we saying to ourselves? That's the cognition. What are the feelings that come up around this? That's the affect. And what are the behaviors that we're engaging in that are goal directed, that are leading to this outcome? And starting to understand these different elements can help you know what's driving the behavior and give you ideas for intervention. And we're going to walk through that here in just a second. Next slide. So let's go back to our case example and let's come up with some intervention ideas for Mr. V. Maybe you've been thinking about this case as I've been talking a little bit about it, trying to think about how you might apply some of these things. You can quickly look back over that history that I read through to see what some of those elements are. In terms of the three T's, if I'm conceptualizing it with that work, love, play, health interview with the problem in the middle, he's had diabetes for 15 years. Now he's getting neuropathy, used to be active, but now pain and stress are getting in the way. So we're seeing a decline in movement. The A1C is rising and the medications are stagnant. So next slide. So if we were to map that onto our image of our behavior pyramid, let's start with the environment. Environment is often the low-hanging fruit. I really encourage you to start there because people feel less guilty about it, and it's an easier thing to change than cognitions and behavior. So number one, he's in a really high stress environment that's probably driving up blood sugars on its own, let alone some of the other behaviors like turning to food and a lot of sedentary entertainment for coping. He's in a food-rich environment, and food really is like the main source of pleasure in his life. There are some limitations with his activity because of his neuropathy, and he's also equated like food is his social time. So if we try to just take that away, suddenly he's not having fun with his wife anymore, and we don't want to do that. We can look at the cognitive side of things. What are some of the beliefs that might be going on? Maybe this is something that he's expressed or something that you're just getting the sense of. One is like we have this dynamic in the family where food is love. His wife's going to be insulted if he doesn't eat her cooking or her food, if he suggests something different. And he really feels like I can't do what I enjoy. So what's the point, right? I used to be this great fly fisherman. I used to tie flies. I can't do any of that anymore. So I'm not even going to try. In terms of the affective side of things, he's struggling with pain. He's got a lot of fatigue, stress, discouragement. We might want to do something there. And then behaviorally, he's engaging in these patterns where he uses food to cope with stress. Food is his main source of pleasure and connection to his wife. And then he avoids activity because of pain. Next slide. So here's some intervention ideas. Knowing those four areas that we talked about, what might be some things that we can do? And you may have thought of other things too that we could continue to add to the list. But for example, we could start increasing his activity, right? Just because he can't do what he used to do doesn't mean he can't do anything. Exercise gives us a lot of bang for our buck because it reduces glucose levels. It helps with stress, which was a problem for him. It helps improve sleep. It reduces obesity. It improves fatigue. So we can get a 5-for-1 just in working on that intervention. So that would definitely be a starting place for me. We want to help him look at other forms of physical activity, encouraging him to start small so we can ensure success. I think this is an area where oftentimes we're well intended, but we give people this metric of, oh, we want to see 150 minutes a week. Well, if you're doing nothing, that feels incredibly overwhelming. And so UW actually did a study to see how they could get 100% participation in an exercise goal, and it was 5 minutes. Like most people can do 5 minutes. So if we start there and then we make a plan to gradually increase that over time, we tend to get a lot better buy-in and success. So we'd work on activity. I'd work on recreation a little bit. Fun, that play area is a really important part of life, and it's something that can be very motivating. So helping him come up with some adapted tools, maybe I'd send him over to OT or PT to figure out how we can maybe adapt some of the activities that he used to do. And I also want to encourage non-food-based fun because he's definitely falling into that pattern, and that's going to send us in the wrong direction with his diabetes. We want to pull in those family supports, have some kind of a family meeting to maybe provide some education about healthy food choices, how wife can maybe adapt some of her recipes to make things a little more diabetes friendly, talk about some other kinds of environmental entertainment and some ways to show love that don't involve food. So you kind of get the idea. And in the interest of time, I'm not going to walk through all of these, but starting to think about how can I set the environment up for success? How can I work on some of these health behaviors that are really going to improve things? Does this person need some training in stress management? And these things don't have to be fancy. Just creating a list of 3 or 4 things they can do when they're stressed that don't involve food can kind of overcome that barrier and get people moving in the right direction. And then finally, cognitive behavioral therapy is really effective for helping with medical adherence, for helping with stress management, and just overall helping people live well with their chronic conditions. So it's definitely something that we can provide in our communities or we can help with here at the Diabetes Center. Next slide. So your key takeaway points. Psychosocial issues are prevalent in our patients with diabetes. They really impact management and they increase costs of care. So I encourage you to start exploring these. Use that work, love, play, health. Use a functional assessment using the behavior pyramid. Do some screenings for anxiety, depression, or eating disorders, but start somewhere and try to pull that element into your treatment. We know adherence issues are common. Diabetes is hard. Just validating this and normalizing it with patients go a long way. And then using some of the problem solving strategies. And then we want to normalize the ups and downs of health behavior change. That learned helplessness is a very real phenomenon. This is a hard job to do. So helping people set realistic expectations, making plans that are achievable one step at a time, and then checking in on their progress. So my final point for you is lifestyle behaviors take years, sometimes decades to develop, and so they take time to change as well. So we want to communicate that through a message to our patients and really help support that change all along the way. And there's some references for you.
Amy, thank you so much. Really great information. We're going to have time for some questions for you. I
Great.
did have one come through the chat. Do you know within the Treasure Valley of who is providing teaching, like cooking lessons? Teaching cooking for diabetes is the question.
Yeah,
Like,
so we have things available here through Humphreys Diabetes Center. They do a number of groups that are just kind of more general in terms of food, ideas of general food principles for cooking. YMCA typically has courses available. Within St. Luke's, we have our lifestyle medicine program that has a lot of hands-on cooking classes, some of which are very focused on whole food plant-based, others are more focused on diabetes management. So there are some resources in the community, and I'm sure there are many more that I'm not listing. So if you are sitting there going, what about this? Put it in the chat so everybody can see it.
yes, please. I think there might be some through the extension office. If anyone else knows of statewide resources as well, can use the chat for that. Matt, you had a question about insurance. Does it usually cover diabetic counseling?
Yes, we typically use health and behavior codes here at our center. So those are based on a physical health diagnosis and needing some kind of behavioral support to improve health and management. And so, yes, Medicare and Medicaid definitely cover those. Early on, we had a few issues with private insurance, but I haven't heard of anything in probably the last 5 years. So we get really good coverage and we do bill all insurance. Yes, we do telehealth. Thanks for sailing this there. Yeah. Uh, Telehealth, I feel like that's one of the good things COVID brought us, right? Is that it really expanded our telehealth opportunities. And here in behavioral health, we're very well suited for it. So yes, we absolutely do telehealth both in Idaho and in Oregon. Any other questions anybody has?